you as I'm not actually a doctor, but otherwise, everything else was correct in what you said about me. So I'll go ahead and get started with how hormone monitors are changing the way providers care for women. So I do have to give some disclosures. So I do work for a hormone monitoring company, but I'm not going to talk about any product specific information. And we're going to deliver this information in an objective, unbiased way solely for educational purposes. So when is hormone tracking helpful in clinical settings? So we'll go ahead and talk about some settings right now. Then we'll go into the research and come back around to case studies. So historically, hormone tracking was mainly looked at for if someone was trying to get pregnant. So are they ovulating or not was what hormone tracking was for. But we know hormone tracking is important for many different clinical situations. So every woman who has ovaries with fluctuating hormones, it's important to their overall well-being and health. So if we think about women who have maybe known or suspected hormonal abnormalities. So we're thinking PCOS, endometriosis, or maybe it's PMS, PMDD. We can be looking for that underlying hormone pattern to see what is happening. Is it a normal pattern or not? There's a big shift in women transitioning off of birth control, looking for more natural ways, and of course, supporting their natural fluctuating hormones. So for those women who are transitioning off of birth control, hormone monitoring can be helpful to see where is that return of coordinated hormones? Are they returning in a normal fashion or not? And then, of course, situational times, like after a woman has had a baby or after a miscarriage, we're looking again for that return of hormones into a coordinated fashion. Other situations is maybe a woman who's had a surgical hysterectomy but retained her ovaries. And so she has fluctuating hormones. She may still be ovulating, but she no longer has a menstrual bleed to track. Same with if she's had a uterine ablation. So those times when I like to say we kind of lost our main landmark or light post that we're usually looking for is that bleed, but the woman likely is still having fluctuating hormones that we can begin tracking. So historically, blood work was seen as the golden standard. And so let's talk about why urinary hormones can be used for tracking women's hormones. So urinary hormones are a reflection of the previous serum levels. So this is a study that you can see that was done in 2015, looking at urinary hormones compared to serum. And there is good correlation. They are, of course, a slight delay because the urine metabolites are breakdown of that hormone that was in the serum. You can see here in the middle graph, this is the progesterone. The top left is LH, and the bottom right is the estrogen. And so the urine metabolite of estrogen that's typically tracked is E3G. So you can see this next study that was done looking at specifically, it is a small patient size, but this was using an at-home monitor that was tracking urinary metabolites. So this patient was, 4 patients were getting their serum levels drawn and urine metabolites at home throughout the cycle. And we can see here that the conclusion from this study was the area under the curve algorithm that they used for the E2 and progesterone, so serum, and then the urine metabolites of E3G and PDG were able to find the transition between the follicular phase into the luteal phase. So finding ovulation and seeing those 2 phases. When we look at why it's important to track hormones, we want to see that full hormone pattern versus just a blood test is a snapshot in time. And so it tells us what the woman's hormones are right now, but what were they 6 hours ago, yesterday, what are they tomorrow? So if we use an at-home urine test, it's a much more user-friendly and really more comprehensive because we're seeing, again, that full hormone pattern, not just one simple snapshot in time. Many patients, for various reasons, don't want to get their blood drawn every day or even every other day, and maybe not even once a cycle. So this is a much more user-friendly way to get patients to have continuous data that you can use for your treatment. So when we're looking at a normal urinary metabolite pattern, what we'd expect to see is this black line is the E3G, or the rising estrogen leading to an ovulation. So you can see that nice big robust hill. It then declines around ovulation and then has a second rise. We want to see coordination between LH and FSH, so these should surge together in a coordinated fashion to trigger ovulation. And then we should see a rise of progesterone afterwards, or the urine metabolite of PDG to confirm it was an ovulatory event. As you can imagine, there's a lot of things that can go wrong. So there can be a mismatch of the hormones, or they can be unbalanced, uncoordinated, some too high, too low. And so that's what we want to be able to see in an ongoing fashion. So we can, with urinary metabolites, track them cycle after cycle. So you can see how a patient is responding maybe to some of the interventions you're doing. So maybe you identified in their PCOS cycles, for example, that they have too high of estrogen in their luteal phase. So you begin treating that and you can see, am I making progress? So historically, with patients with PCOS, typically what we were doing to monitor them was, are their cycles becoming more regular? So were they, they historically were 40 to 60 days. Now they're getting more like 30 to 40. But as you can imagine, that takes a long time to see if you're making the progress you want to see, because you just wait until their next period comes. Or you might be doing blood work, but again, you're probably not doing that on an every cycle basis. So maybe after 3 cycles of data. So when you're doing hormone monitoring in the urinary metabolites, you can see then, have they made any progress in this particular cycle? So an example I'll give is a provider who had a patient testing and they could see right away that their estrogen levels were really high. So they did an investigation in her lifestyle and found that she was eating a vegan diet with high amounts of soy. And so they adjusted what she was eating, and within 3 weeks, they could see a change in her urinary metabolites. So some things you can see immediate change. Others, of course, take longer to have that positive change that you want to see. But by remote monitoring it like this, you can see if they're responding positively or negatively. So we find that patients who are testing at home, they see the results. Think of it kind of like a continuous glucometer. When they eat something, they check their level, they see it spike their blood sugar. It's that immediate feedback to them. Same way when they're testing their urinary metabolites at home, they're able to see, okay, so when I follow these interventions and recommendations from my provider, my results are looking better. And then when I fall off the bandwagon and stop doing what I'm supposed to, my results become worse again. So it can be 2 ways. It can be positive reinforcement or even negative reinforcement. So there are several researchers, universities that are doing studies on tracking urinary hormones. So you can see here, for example, Johns Hopkins, University of Melbourne, University of British Columbia, and more. And again, this is really closing the gender gap because we are able to see, for example, how athletes respond to different interventions in their follicular versus their luteal phase. And we know, for example, that the hormones are, in a sense, ever fluctuating. And so it's very hard to do studies without putting this into the equation. And historically, it was very hard to account for the fluctuating hormones, but now we have the ability to track it easily at home in a way that can make the research studies even more valuable and provide even more data that can be replicated and seeing interventions and seeing how patients respond. So there are some studies going on right now about urinary hormones. This is the pilot that you can look up and read about, but the published study is supposed to be done about May. This researcher is doing a 50-patient, 3 cycles each analysis of women using urinary hormones. They are tracking their temperature, getting their blood work done, and serial ultrasounds as well. So again, taking those 2 golden standards of the ultrasounds and serum and using these urinary metabolites to really create a foundation that this can be used for many different things, such as PCOS studies, athletes, irregular cycles, perimenopause. And so this data is going to be very valuable. We see some already published studies. So this is a study done out of the University of Toronto. And this is women were wearing and I think it was a 49 participant. It was supposed to be 50, but one dropped out. So 49 participants wearing a Fitbit. They were wearing a continuous glucometer and doing at-home urinary hormone metabolite tracking. And you can see a very distinct shift in the glucose values from when the woman was follicular phase versus luteal phase. So again, just showing how every part of a woman's life is different based on how her hormones are and what phase of the cycle she is in. Many times we think of hormone levels from fertility stands. So I think we can't ignore this. We know that there's a lot of fertility challenges. So women who are using a standalone urinary metabolite, such as only tracking LH, rates we know are increasing. So more and more couples are struggling to conceive. And of course, that has a negative impact on their work situation and impacting other areas of their lives. So there was a pilot done as hypothalamic amenorrhea are just a few. They had a intake visit with their provider, and then they began hormone monitoring at home. 44% of the participants got pregnant after 2 months of working with their provider. And if we compare that to other public success rates, we'll call it. So patients with PCOS typically have a conception rate around 25 to 30%. If we look at IUI pregnancy rates, it's around 20%, and IVF is at 47. And so if we look for hormone tracking after 2 months, it has a huge impact on the success rate. And working with a provider, of course, even is just as important. They also found that the patients were very engaged and compliant throughout their treatment. So they were looking forward to a provider looking at their data with them. So I think that holds true for any data that a patient is collecting, whether it's their blood work, their continuous glucometer data, their urinary metabolites, anything that a patient is tracking. When they have a provider then who will look into it, look at it, help them interpret it, and help them make interventions, are much more compliant with their treatment and book their follow-up appointments. So these are just a couple of examples of those patients in that clinic. So on the left, you can see patient number 1 had hypothalamic amenorrhea. And so you can see, just to give you a quick tour of the tracking here, along the bottom is the day of the month, and then the cycle day, and then the data points. The black is the urine metabolite of estrogen, so the E3G. Turquoise is LH. But even without me teaching you that, you can tell that this is not a good scenario. These hormones are not good. They are flatlined. So over the course of treatment with their provider, you can see the before treatment is May, and then their conception cycle here is September. So over the course of months working with their provider, they did end up conceiving on an ovulation induction cycle. But just the drastic difference in the hormone patterns is in and of itself amazing. Then the patient on the right is a diminished ovarian reserve complicated by obesity, luteal phase defect, and hypothyroidism. This patient was not as consistent with her testing, but even so, you can see that these hormones are not coordinated. We don't see evidence of an LH surge triggering ovulation and changes in progesterone. And then you can see, again, over the course of time working with the provider, they did metabolic nutrition, Trulicity, Clomid, HCG trigger shot, and progesterone, and this is her conception cycle. So overall, with this pilot, they found, again, that 44% of the participants conceived after 2 months working with the provider. And overall, the patients were very pleased with, again, this pilot and being able to see their data. And in the end, by the 77% of those trying to conceive ended up successfully ovulating. So again, we know that the end goal of conception is important, but getting women to have regular ovulatory cycles is important too. So I think that 77% stands out to me as well. Okay, so let's do a deep dive into how do we interpret hormone patterns. So first we can look at, are the hormones coordinated? Do they make sense? Are they balanced? And so again, to give a quick tour, black lines are estrogen metabolites, E3G. LH is the trigger to ovulate, and then the PDG is the rise of progesterone after ovulation. So there's really three questions you can ask yourself, and that's what the next slides are. So are the hormones coordinated? So if we look at this top picture, we see that nice rise of estrogen, it declines and then rises again. Whereas in the bottom picture, we see there's not really a pattern that makes sense. So the estrogen is not leading up to an LH surge. And so this woman, although she's having bleeding episodes, she, from this data, is not having ovulations. So it's withdrawal bleeds or breakthrough bleeding. And we can see that a bleeding in of itself is something we can track, and it is important to track, but it does not mean that the hormones are balanced. We then, of course, can look to see, are the hormones within normal reference ranges? And so the urine metabolite values are different than serum. And so, of course, if you're very used to looking at serum levels, this will be kind of like learning a foreign language. At first, they may not be very easy to interpret, but over time, this will become easier. So when you're looking at, are they within the reference ranges, you're looking to see, are the majority of the data points fitting within the typical curve that we see? So this example on the right is, of course, an abnormal where we see the estrogen or E3G is not only high, but it is very fluctuating as well. Of course, we can use the cycle length. So is a woman having a regular cycle that fits between the typical 25 to 35 days? And it should be within a small range. So the variation from one cycle to the next should usually be 3 days or less. So a woman might say, my cycle is typically 25 to 28 days or 31 to 33 days. But what we don't want to see is someone who's having a cycle that's sometimes 25, sometimes 35, and everywhere in between. So although it technically fits within that range of 25 to 35, there's too much variation. Then we can look at each hormone level one at a time. So this is a LH value. So we know, again, the purpose of LH is to trigger the ovary to release the egg. So this is an analysis done on 1,624 self-reported conception cycles. And this is, again, the urine metabolite of tracking in the urine LH. And so we see here that for the bulk of users, we have this very clear rise in LH that goes up and down. Of course, there are some outliers that are in this lighter blue. So there's two questions you can ask yourself when you're looking at, is LH normal? So does LH follow a low pattern throughout the whole cycle except for 1 to 3 days? So that means that their spike of LH should occur over 1 to maybe 3 days. So this top picture is that pattern that we expect to see here on cycle day 12. Whereas these bottom two pictures are two problematic LH patterns. So the bottom left is a patient who has chronically or baseline high LH. So in this pattern, which sometimes we can see with PCOS or other hormone abnormalities, this is desensitizing the ovary. The ovary should get exposed to a high amount of LH once that triggers it each cycle. So when we have this baseline high LH, it's going to make the ovary less responsive when it's supposed to be releasing the egg. And then the example on the right is a very large LH surge. So if you count it out, you could argue that it's 5 to 8 days long, depending on how low you want the LH to go. So this is a very abnormal type of LH. It did trigger the ovary at some point within these 5 days because her progesterone did go up afterwards. But this is not ideal, and this is not what we want to see in someone who's achieving optimal health. So the three common LH curves that we want to see is either just a traditional spike that goes up, comes down. It may go up, come down a little bit, and then back up, so like a biphasic, or it may be more of a plateau where it goes up, stays elevated for another data point, and then comes down. Again, we want to see this over the course of 1 to 3 days. So LH is actually the easiest of the four hormones to track. We're moving into one of the most difficult, which is estrogen. So when we're tracking estrogen and urine metabolites, E3G is one of the urinary metabolites, and this is what this graph is going to be depicting. So again, we're back to that 1,624 self-reported conception cycles. We see there is a mean and median line, and then the bulk of users is in the dark gray, and we fade out into the outliers. So with this information in mind, we can ask ourselves three questions with the estrogen pattern. Does estrogen rise leading to the LH surge and then decline? So a normal example would be this nice rise here. When there's a lack of rising estrogen, this would make us concerned about follicular development. So are we maturing an egg? Is there uterine lining thickening? This woman's still having an ovulatory event right now, but this may not continue if this is not addressed. So this pattern could represent someone who has suppressive or restrictive eating, so low calories, lack of dietary fiber and fats. This could be someone who is over exercising, but something is completely suppressing the estrogen. And so again, this is not going to be ideal if it's not fixed. The next thing we can look at is, does estrogen decline and have a second rise? So after the ovulatory event, estrogen should take kind of the back seat. Progesterone should become the dominant hormone, but there still should be some estrogen in response to that corpus luteum formation. And so when we see no estrogen at all, this is making us concerned that did the woman ovulate at all? Did she release the egg? So of course we can look at progesterone, so we can help correlate those together. But when we see more of like an inconclusive pattern like this one, then it makes us concerned, did the woman again have such a poor egg quality that the corpus luteum is very suboptimal? Or is this representing a luteinized unruptured follicle or a partial rupture? What has happened that these, again, hormones are not ideal? And finally, with estrogen, it should be a, as I like to call, large hill and then a small hill. So in that pattern, big estrogen, then small estrogen. When it is similar to each other in the follicular and the luteal, or reverse, such as this bottom example, this is a hormone abnormality. So you've identified an issue with the estrogen. It's lacking in the follicular and it's too much in the luteal. So a mismatch here. Many of these patients have symptoms. So they can have heavy periods, they can have PMS symptoms, but they will usually have something that's pointing you towards this. But I like to say this is a good example where a single blood test would not identify we'll say, how big this problem is. You might find that on one day the estrogen is too high, but you don't know that every day it is high. Or if you're doing another type of test, maybe test like a Dutch Complete, for example, that's typically timed 7 days after ovulation. That particular day might not be their highest estrogen, and it also, again, is not reflecting the full luteal phase. So continuous testing like this can really identify problems. This patient in particular, she had very high prolactin levels outside of pregnancy, outside of breastfeeding. And so with her provider, she was able to begin treatment to manage that, lowering that estrogen level, getting it to be much more balanced. And the exciting news is this patient was able to do that work while she was engaged. She then got married, within 3 cycles, was able to conceive. So I think that's one of the reasons why I'm so passionate about this data, is we can do a lot of work in preparation for conception, or to really improve people's quality of life, because this patient did have PMS symptoms and heavy periods. Next, we move into progesterone patterns, or PDG, the urine metabolite. So again, same 1,600 patients, looking at the mean and median line, and we see this nice bell curve of progesterone. Now these patients have conceived, so if you start looking at about 11 to 13 days after their LH surge, most in a non-conception cycle, their progesterone would be dropping, but these patients have conceived. So in the progesterone pattern, we want to see, do we have a good amount of progesterone? So is it within the reference range, and is it higher than estrogen? So a quick way to do an assessment on that estrogen versus progesterone is progesterone should be much bigger on the graph than estrogen. When they are nearly on top of each other, that is a problem. It's either too high of estrogen, too low progesterone, or sometimes you can have both, where they're actually in a reverse pattern. So again, a quick assessment of progesterone you can do is it a nice big bell curve? Is it higher than estrogen? And of course, you can go back to this picture here and look within the reference ranges. We also know that progesterone is what helps create that luteal phase because of the corpus luteum formation once a follicle has ruptured and released the egg. And so a normal luteal phase length should be between 11 and 16 days. Implantation tends to, for most women, happen at about 7 to 10 days after ovulation. So when you calculate a luteal phase that's less than 11 days, it does put the woman at risk for early miscarriages and failed implantation. And again, if we have this lack of progesterone, these patients typically are experiencing symptoms. For an example of this picture here, this estrogen is too high, this progesterone is not ideal. So again, this patient may be experiencing PMS symptoms, heavy periods, or difficulty sleeping or something happening in her luteal phase. FSH is, we'll say, the last hormone to the party. It's becoming really popular now to be tracked in urinary metabolites, but there is less information on it. So you'll see here this analysis is only on about 300 patients. So if we're looking at conception cycles, there's of course more an ideal levels of FSH. FSH can be very helpful to track in of course, situations outside of trying to conceive be helpful for perimenopausal patients, so tracking that transition, and as well as hormone abnormalities such as PCOS. And I'll show you a chart example of that right here. When we are looking for an ovulatory event, we should see nice LH and FSH surge together. When we're missing that FSH, it does point us in the direction of this may be a failed ovulation. So this woman is trying to ovulate, but it does not respond. And I'll show you this woman's full chart in a moment. So the first thing you can look at with FSH is, do you see LH and FSH surging together? Next, we can assess the ovarian function at the beginning of the cycle, looking at that FSH. So we expect a small change in FSH to recruit the next follicle. But when we have really high FSH levels, that can indicate diminished ovarian reserve or perimenopause. And we can use that in conjunction with the rest of the data to really see where these women are. Of course, if we see FSH in an ongoing elevated pattern, this really points us to either perimenopause or a big problem. So ovarian insufficiency or diminished ovarian reserve, again, problems like that. We can also see it with other situations that are more rare, such as women who are on chemotherapy or drugs that are causing these elevated levels. So what I'd like to show you is some now case studies. So this is a patient with PCOS and irregular cycles. She does happen to be trying to conceive, but that doesn't really, this could be just a woman trying to manage her PCOS. So she's been trying to conceive for over a year. She has known that she's had PCOS since age 18. She's now 26. She reports history of irregular cycles varying between 31 to 52 days. About a year ago, she got her cycles more regulated, but they're back to irregular again. So in her first cycle that she was tracking, we can see in general her hormones don't look too bad. And what I mean by that is she has, rising estrogen. It does decline per se. It does have an LH surge, FSH surge. She does have changing progesterone, but she has what I consider a warning sign that something is not going well. And that is her estrogen is not perfectly timed with or coordinated with the LH surge. It doesn't reach its climax at the right time. And then it declines, but it does not stay lower than her follicular. So she does have that kind of reverse pattern that we talked about. So this is, again, what I consider a warning sign. And in this patient's case, unfortunately, it got worse instead of getting better. And she moved into this cycle. So this patient did have a long cycle, but there's much more going on here under the surface than just a long cycle. She had what looked like a coordinated normal pattern towards ovulation. She had rising estrogen, an LH surge, but unfortunately, her body did not respond to this LH surge or this trigger. So this represents a non-ovulatory LH surge, where the body is trying to ovulate and fails, and then it tries again. So we have a secondary rise of estrogen, and then we get a second LH surge, and this is the event that actually triggered ovulation. And I know that because her progesterone then went up. So if we think about this from a clinician standpoint, you have a patient tracking to, again, try to manage her PCOS, and you say to them, I want you to do blood work or do a Dutch complete 7 days after ovulation. She would have found this LH surge, counted out the days, and done the blood test. The results would have come back, and it would have said she didn't ovulate. Her progesterone would be low. The Dutch Complete may not be very useful data either because it's not actually her luteal phase. When in actuality, the timing of that test should have been way back here about cycle day, 37 instead. So the timing of this test would have been off. From a patient situation, if we think about her, trying to manage her PCOS, she's trying to conceive, she would have thought she ovulated here, likely timed intercourse well around that attempt at an ovulation. If she would have stopped testing and just waited and then taken a pregnancy test, she would have been very frustrated when the test was negative, but she also was not getting a period. That would be very confusing to a patient. When in actuality, when she's testing with this amount of detail, we can see clearly what happened. It's kind of like a stutter step, and still not ideal. This patient could have conceived. We're not saying that she couldn't. She could have conceived here, but it's again not optimized, not ideal. Next case study is a patient with regular cycles, but overall the hormone levels are low. So if we think about how patients can progress through time, obviously hormones fluctuate and their situations change. So this patient was actively trying to avoid a pregnancy after having a baby, and then now she's trying to conceive again. And so she has one pregnancy, one baby. Baby was born December of 21. Her BMI, you can see, is 33.6. She does report being heavier than what she was before. And she is still actively breastfeeding, but she has had 10 cycles since her cycles return. So she's, 2 years postpartum. She's had plenty of cycles. They're all regular, but she reported being concerned about her hormone data changing. And so I want to show you what her hormone data did look like at first. So this is October, and you can see that it looks pretty good. Estrogen's rising, declines, has a second hill. She does have changes in her progesterone. Her progesterone levels overall are low and not ideal, but this looks pretty good. Then she started being concerned about her data, and this is what it flipped to. So we can see now she has minimal estrogen changes leading to her LH surge. Her levels after ovulation are even worse than what they were before. And so we can see a distinct change in her data from October to now June. So this would prompt you if the patient came to you and said, I'm concerned about my hormone levels not being ideal or they've changed, something like that. This really would show us that there is work to be done if we're trying to optimize this woman's hormones, especially if she's about to try to conceive. So this might warrant, again, an investigation to find out, is she now maybe really restrictive eating or removed all the fat from her diet because she's trying to lose some of that baby weight because her BMI is 33.5. So really figuring out, what is happening in her situation. It may help you to treat her faster. Some other situations that you might find is overall low hormones. So this is an example where, again, many of these are trying to conceive examples, but this could be just a woman who's trying to optimize her hormones. And we see overall very low, ongoing low estrogen and low progesterone. And so again, this woman is likely not feeling well, especially in that luteal phase when we're supposed to see nice, big, robust progesterone, and she does not have it. This is, again, that warning sign of that too high of estrogen in that luteal phase. And this is showing that suboptimal ovulation where we're seeing, again, too short of a luteal phase. Progesterone's not really ideal. It did shoot up. So if you did your blood work right here, again, 7 days after ovulation, this blood test right here might look like her progesterone looks just fine. But in actuality, it really is only 1 day that it was in ideal ranges. The rest of the data points are really too low. So what I'd like to spend the rest of our time is looking at the transition into perimenopause and how hormone tracking can be very helpful for this time frame. We know there are many women in this time frame, and they can be in perimenopause for 2 years, 4 years, 6 years, 10 years, and often they are experiencing symptoms that they come to a provider for. So if we look at, for example, the revised drug criteria, that's a published article that you can look at, looking to stage a woman throughout her transition. I love and hate the straw criteria because I like how it's standardized, but it's not specific enough to truly help women to see, where they are within their transition. So, for example, we see that the blood work that you might do, it says FSH is variable in early transition, then it might be high, but then it goes back to variable. And so it can be difficult to see which phase are they really in with just FSH values, for an example. You can, of course, look at the woman's cycle changes, but those two data points are really all that's currently given on the Struck criteria. If we look at it, another way, we can see that the woman may start to see slight cycle changes, but we can see normal to variable FSH. Then we look in the next phase, again, variable FSH, cycles variable. They're sounding very similar to each other. And then we finally get to high FSH, and then the woman stops having her period. So there's not really enough data currently to help women in this perimenopausal transition. So there is a graph here from Dr. Stephanie Hayes, and this graph that she created is also on another webinar of PLMI if you're wanting to listen to it in more detail. But she really shows how the FSH on its own is really not enough. Tracking estradiol is as very important as well. But again, estradiol in blood, unless you're doing it every cycle, may not be showing you everything that you want, so that urinary metabolites are very helpful. So if we think about a woman who's transitioning, she's in her fertile years, the values are within normal range. Then we start moving into early perimenopause, and we see the FSH levels might be trending a little higher. The estrogens might be trending a little higher. But then we start getting this suppression of the FSH because of very high estrogen levels. And so you may not see the FSH high, or they may not be helping you to see that they're now, transitioning further and further until you finally get to the phase where the FSH is rising significantly and the estrogen starts to decline. But what's helpful to understand here is you might catch a patient that just comes to you and you test, and you don't know if they're in this phase over here where the FSH is slightly elevated, the estrogen's kind of middle of the road, or are they at this crossroads? So it's very helpful to have additional data. So if we look at, again, urinary metabolites, we can see here, this is a 42 female. She has irregular cycles and she's on her way into transitioning to menopause. So what we can see here is she has ongoing elevated FSH levels. That's the gold color here. And she's tracking it, every few days and then started to space it out. You can see she's actually on cycle day 311 when this chart ends. So she is 2 months away from the clinical diagnosis of menopause if she does not get another period. But the ongoing data actually helps us to see the normal physiological dysfunction that's starting to happen. High FSH, her LH is no longer trigger and ovulation coordinated, it's just ongoing elevated, and she has low estrogen. But we can see, now this is a biologically older woman. She actually has much different hormone patterns. So this is where I'm trying to prove the point of just looking at one blood test will not tell you everything about what's happening on the hormonal level. So you see this woman, again, biologically older, she's 49, but her pattern is much different. She has this high fluctuating estrogen and not coordinated. We're not seeing an LH surge. We're not seeing changes in progesterone. So a patient that has this high fluctuating estrogen, she may be having significant symptoms, or someone with very low estrogen may be having significant symptoms. And so I suspect how you're going to treat those patterns are going to be different based on what you're seeing. We also know women as they age, especially throughout that perimenopausal transition, you can see here the -3 stage, -2, mixed, -1 plus 1. Their progesterone levels are dropping. So it's one of the first hormones that we see that significant decline in. And so many of these women can benefit from progesterone supplementation. And I'm not going to tell you which way to do it, but I'll just show you that the hormone tracking can actually show you that sign that they have that really low progesterone levels. So here's an example where the woman had a very late LH surge, and then you see her progesterone levels start to change. So if you see these levels cycle after cycle with low progesterone, a short luteal phase, this is someone who might benefit from what I like to call a cooperative HRT, where the progesterone is given after the LH surge to support her natural process of ovulating. So I know many clinicians do like cyclical progesterone or daily progesterone, but really timing it up after ovulatory events is going to support the process that's already occurring. And we know women in perimenopause can have an ovulatory event and then an anovulatory event and go back and forth. And so helping them to time up their HRT can make it to be even more effective and help the patient to feel even better versus just jumping right to, let's say, daily or even the timed, like cycle day 15 through 28, something like that. If the woman is still having events triggering ovulation, it'd be much better to time it up. This is another example of that low progesterone. So this woman's 52. She is still having coordinated hormones. And we see this time and time and again. You can't only look at the biological age. This woman has changing estrogen towards ovulation and LH surge, and then her progesterone changes. But this progesterone is very weak. It's very low and a short luteal phase. And again, this is an example of a woman that would likely benefit from a timed progesterone supplementation. Once a woman gets into a pattern that is no longer coordinated, so this woman here, she's 50, it's having an anovulatory event, it's no longer coordinated with anything. Now, this might be where the patient benefits from more of a daily dosing, or you could, of course, try the cyclical 15 days, start on cycle day 15 through 28, something like that. But until the woman gets to where she's no longer having her own coordination, these women may do better with the cooperative HRT. And of course, we see many different things that can happen in the perimenopausal transition. So more studies need to happen to see, are there patterns that keep recurring? Now that we have this much detail on women's hormones in these urinary metabolites, we'll really be able to, again, get more research done, really see what's helping women in the best way. And really, I'm excited to be a part of this because we are seeing just so many providers actively engaged wanting to see this data and are doing amazing work for these patients. And this is just an example of a same age as some of the patients we've already seen. But again, this is a much different pattern. She has overall estrogen levels that are no longer coordinated, but also not high. She's more of a low pattern. So you may want to treat this differently. So that is the end of the content. Love to take anyone's questions. I should have asked if you wanted to interrupt during, but I'll take anybody's questions now.
All right, that was great. Go ahead, Yornine.
So for somebody up in my age bracket, I'm in the 70.
Okay.
And so obviously I'm not cycling any longer. How do you have testing for, like seeing whether or not there's issues and any intervention?
Sure. So you're saying, is your tracking urinary metabolites of hormones helpful with someone who is fully established as postmenopausal? Am I understanding correctly? Yes. So currently that's where there's the least amount of data. So currently what I see happening is women who are within 2 years of their official diagnosis of menopause. So if we think up to 3 years past the last period, that's where I see it being used. There are some clinicians who are, I would say, are experimenting to see, this woman has symptoms that are not really explained. Are they having exposures to something that's affecting their hormone values in another way? So if we think about, high amounts of adipose tissue or exposures, things like that. But again, it's the least amount of information currently is available on that category. Some would argue, can it be used to see, like, am I achieving what I want with my HRT? So I'll just explain that because I'm sure people have questions there. Currently, urinary metabolites cannot be used to calculate backwards like a serum level. And so you can't look at someone's urinary metabolite and say, okay, well, that's 20. So then their serum progesterone must be 30. And so that's what I wanted to achieve. So it's much more of a symptom management and then seeing, have I achieved the change in the data that I wanted? So let me just show you an example. So let's say it's a patient with the hormones that look like this, and So you begin your interventions, and I see a lot of providers doing lifestyle modifications, supplements, and then starting, for example, this woman may get put on a daily progesterone. So if a patient's taking oral, vaginal, injectable progesterone, those will cause the serum levels to significantly increase, which then cause the urinary metabolites to max out at the top of the scale, usually at 30. So the progesterone would be maxed out. But what you would be looking for is not the high progesterone. What you'd be looking for is, am I balancing out this estrogen in the way that I want? So topical, like an estradiol patch, or progesterone creams, anything that's absorbed through the skin, we see only a slight change in the urinary metabolite, or sorry, a slight change in the serum, which then only causes a slight change in the urinary metabolites. And so you can track women's underlying pattern even while they're on, let's say, an estradiol patch or a progesterone cream, something like that.
Thank you.
Mm-hmm.
Rosemary, is it accurate to say that this is a more, I guess, intricate way of doing cycle mapping? Because in cycle mapping, I think you only sample like 11 times in a month. But this one, as you could see, and that's also another question. So for every day, this patient will be getting a sample daily, and I'm sure there will be, I mean, in relation to costing, you will be dispensing a wand. I think that's what you're using,
Yes. Yep.
right?
A wand per test. And so they collect a first morning urine sample, they dip a wand, and then they insert it into the machine to read it. So it's an at-home test. The cost for like 3 months of monitoring nearly every day runs about the same as one cycle mapping. And so you can get 3 months of data compared to just one. And as you mentioned, the benefit is not only that you get more data points, because you can space these out. So, a patient could choose to test, let's say, every other day to reduce the cost. But with let's say you were talking about like a cycle mapping of some kind, the patients don't really get to choose what day they're testing. It's already set up for them ahead of time, and they're told when to test. They dip, and then they may.
Yeah.
Oh, you got muted,
Yeah,
Rosemary.
that was me again.
Oh, muted. Okay, can you hear me again?
Yeah.
Yes.
That was me.
Okay. So for like a cycle mapping that a patient mails their samples in, then they wait for the results, you're not seeing it in real time, and the patient's not getting to choose what day they're testing. So let's say a patient has a abnormal cycle in PCOS, you wouldn't know that as they're testing. Then you mail it in, then you wait for the results to come back. With this, because you can see it in real time, you can see the progression, and you can see, oh, we need to test more often, or we can test less often. So it's much more user-friendly and provider-friendly than a cycle mapping. It replaces cycle mapping very well. What it does not replace is if you're looking for something more specific that obviously this is not available for, like if you need testosterone or of course, any of the androgens that's not available currently, or if you're looking for like metabolic pathways, so someone's cortisol, their adrenal function and things like that, that you might need additional testing. But yes, this replaces cycle mapping very well.
So you don't request for like the whole day. You're just showing this for demo purposes, right? It's not like
Yes.
every day we instruct. I mean, I do get the instruction of trying to catch ovulation. Maybe that's something
Hmm.
that you will do in succession, but
Yes.
yeah, it's not something that's a standard for clinicians to do for their patients.
So they can, a clinician could tell the patient, I want you to test every other day, or I want you to do every 3 days. And then you can decide with that amount of information. So maybe you do every other day for 3 weeks on a perimenopausal patient. You're like, okay, your pattern has not changed over the last 3 weeks. I can see what's been happening, and that's plenty of data. And so some clinicians will have the patient then begin an intervention, and they may continue to test during the intervention, or they pause testing and then they bring it back out if now there's a change. So I see that be done with, they put them on a type of HRT. The patient's doing well, they stop testing. Now we're 6 months down the road, a year down the road, the patient says, my symptoms are back. Why is this happening? They get testing again. They see, oh, wow, like the complete change. Maybe her hormones looked something like, we'll say like this one, and now they look like flatlined, completely different pattern. And so it can help to explain why the patient's not responding as well as they used to.
What cases do you recommend that they do successive monitoring other than ovulation, trying to catch ovulation?
Yeah, so if you have a known abnormality, so like someone with that reverse pattern of estrogen, for example, we want to keep testing until we get that balanced. Once we get them to an optimized state, then they may go on like that for years and be fine until a situation changes. Now they're postpartum or now they're perimenopausal, and then they can begin testing again. So situations like that where you're watching to see an improvement, or if you have someone who, again, is in a changed situation, and of course, those actively trying to conceive are testing from cycle to cycle.
Go ahead, Dr. Bell. I have some. I'm going to dig up the email questions there.
It's I try to keep things simple, and this seems to make things more complicated.
Yes, I will challenge you on that. It's simpler because they can do the testing at home.
Okay,
It
well,
makes it more complicated because it makes it personalized, which we know this is what a patient obviously wants and deserves. And so we're able to take this data and really personalize what they are doing. So of course, I'm not telling you how to treat someone's, let's say, high fluctuating estrogen, but you'd be able to see, is what I'm recommending actually doing the changes I want? And if they're not, then we need to modify it. And, it's another, I like to say that we're taking the patient from like a 2D, now we're to like a 3 or a 4D, the way that we're looking at their hormones.
I have a question.
Mhm.
I think I have a perfect candidate for that, but I see what you think. I just saw a lady today who came to see me as a primary doctor. She's 28 years old. She used to be on birth control that she stopped in February, and ever since February, she haven't gotten her period back. I did briefly see her labs that she done in May. They were conventional labs, not urinary metabolites. Her estrogen was, I think, was like total estrogen was like 86. Her testosterone was 43. I think progesterone was 1.1. But she haven't had any testing done since she had went to see her gynecologist. They said, okay, just wait a little bit, see what happens. She has terrible acne.
Oh, no.
So it's obviously she needs more than just wait
Yeah.
a little bit. So I think that this is actually very interesting. It was a perfect timing. So
It is perfect timing.
so what are your thoughts on that?
Yeah, I think she would be a perfect candidate because she can, begin to test immediately. You can start an intervention with her to try to manage the abnormalities in her hormones that you already know, and then you can watch as it progresses. I would say it's not normal for her not to have a return of her cycles in 10 months.
Right. Yeah, she has no other issues, like there's no diabetes, no cholesterol, like she's overall pretty healthy lady, never had any miscarriages or pregnancies. So
And do you know what she started the birth control for? Sometimes that can be a very helpful cue. Unless they only took it for contraceptives, but if they took it for heavy, painful periods, irregular cycles.
I believe it was only for contraceptives, and I think she was told that she has polycystic ovarian syndrome.
That's what I suspected based on what you had shared. So for her, she is in a current, very unmanaged PCOS picture where she is in complete amenorrhea for now 10 months. And so it's probably going to be, quite a lot of work to manage that, but we don't know how resistant of a form she has until we start any types of interventions. But what will be really nice for you to see is, again, I've actually seen women who are in that amenorrhea state. And then as we start treating them, sometimes they can go from, let me see if I have a good example here. They will be like flatlined. So, something like this, but even worse, flatlined. Then they can go into actually like really high estrogen that's trying to be coordinated with something, but the LH hasn't caught on yet. So you can actually watch as like the pieces start to come together. So
I
you
think
start
LH
seeing
was like 4 also. The LH was 4.4. So it was kind of like not really consistent. Yeah.
Yeah,
And you can't really
nothing's
say, as you said, it was random testing. So
it's
you
just
can't really.
random. Yeah.
Mhm.
So she's, I mean, we know a lot of problems with her data just based on what you shared with me. So it'd be very interesting to get her testing, but she would be a candidate to do like the every other day testing because we don't know how many weeks or months it's going to take her to then have a coordinated hormone pattern to trigger ovulation, then have high progesterone. But she would be a perfect candidate to get started.
So I'll just need some advice how to get her a test and which would be the best one.
Mhm.
I don't know if you
Yeah.
can do it all during this conversation or
We
guess are
can
we
talk
done
about
with-
it. Yeah, as soon as the educational piece is over, we can discuss it.
Thank you.
Mhm.
Okay, just
I
for
think,
everyone's information, the link for the credits is in the chat. Okay, and that'll be on the next. They're always on the emails also. Okay, so that you get every week. So sorry to interrupt, Rosemary.
yeah, no problem.
All right, so let me see if I have this straight. This is a machine. I call some place and I order this machine, and it comes, or do I have them in my office and I say, "Here, do this." How walk me
So,
through it, because
yeah.
I'm old and I don't change.
Imagine Dr. Bill's having menstruation.
Yeah.
Yeah, he needs to track. Um, so, a patient can actually purchase this themselves. It is an FDA cleared device that does not have to be prescribed, written, or ordered for the patient. They can buy it themselves. They go on the website, they buy it, they buy the analyzer, which is a one-time purchase, and then they buy wands. And the wands are like one wand does one morning's test. So first morning urine, and it can track up to 3 metabolites at once. So estrogen, LH, and progesterone are all in one test. So one wand, 3 hormones. If they want FSH, it's a separate wand currently. And
Okay.
so the patient gets it in the mail. They can start testing immediately. They don't have to wait till like the start of a next cycle or a certain phase of the cycle. They just start testing immediately. The only days they are not advised to test is while they're on their heavy days of their bleeding, their period. Otherwise, they start testing. They can see the data graphed out for them in the app, and then the provider has access to a HIPAA compliant dashboard where they can see the data in real time. So maybe I was seeing this patient I was about to have a visit with her. I could pull open the data, view it all, and I'd even see this morning's results. And then I could review that with the patient during their visit. And of course, be looking at it at any point that I need to be checking it.
All
Is
right.
that clear?
So would you do this whole thing before you would advise somebody on anything, or would you go through and as it's going on? After 14 days, you see that the progesterone's not moving at all.
Yeah, so it really depends on what I'm looking for. So sometimes there can be, only a week's worth of data and it's enough to say this is a problem, whereas someone else I need a baseline. So what's really great about this is you can actually have a patient be testing before you see them. So, many providers have a time period before they see their patient. So maybe they book an appointment with you in 3 weeks. Well, on their registration form, they say they have long irregular cycles or they have what seems like hormonal acne, or they say something that triggers, oh, I'm going to want hormone testing on them. They can already start testing. You can before you even see them for a visit, you can recommend go get this testing done. I'll see you in 3 weeks, and then we can look at the data then. So we can be obtaining very valuable data even before their visit.
Okay. All right. So can you walk us through this? So this one that you have on the screen here. So what do we do? What do we do with this? I mean, this is
Yeah.
So what do you do with it? Carol, where are you?
Well, there's a lot of things that we can do with this. So I'm not going to tell you exactly how to treat the patient, but I'll tell you that this is someone who I'd want to know what is her exercise, what is her diet, what is her lifestyle, what is her sleeping patterns. Does she have high cortisol? Does she have that's robbing her body of her hormones? If we do all this workup and we find that there's really, we'll say no problem area, then this may be simply representing lowering hormones of perimenopause. So this patient may be having an earlier transition, but she's actively trying to conceive. So if she wants to conceive, then we're going to have to boost her hormones up. And there's lots of different ways that we could do that. But now you know what we have to do. We don't see a problem that we have to fix first. We now are just going to be targeting and improving the hormones themselves. So I've seen providers do things like post-peak progesterone. So they're taking bioidentical progesterone. This patient may need things like DHEA down the road, ovulation induction. There's lots of interventions that we could do. But this data is telling us that we have to do a deep dive to figure out if there's a cause of low hormones. If there's not, then we can start trying to target and just boosting these hormones so she can conceive.
Can you measure?
That's actually what I wanted to do with this patient. I mean, just looking at the spike, the LH here, and then you don't get that progesterone increase that you're seeing. So is it safe to say that you start your oral progesterone, let's say on day 13, moving forward?
On which day, sorry?
On day 13, 13 or 14, you can start your oral progesterone already, moving forward to increase that progesterone level. I mean, is that a good intervention for this case?
I would actually argue no. I would start it on cycle day. If she's having her trigger here on cycle day 18, 19, a timed up progesterone.
Yeah, that's the one I want to see. I thought I was reading at the bottom 13, 14.
Sorry. The date, September 13. Yeah. So I would start it on September 16, once the LH surge has happened. And then her progesterone is on her own, should be rising because the process of ovulation has occurred. And now we'd be supporting what her body's already doing. So yes, she would be a perfect candidate for a bioidentical progesterone starting about 3 days after her LH surge.
Yeah, because in clinical practice, we kind of just blindly do this. As you can see now,
Right.
you have an actual exact approach when you're going to introduce that progesterone in helping this patient to, if you want to make her ovulate or have a good amounts of progesterone in the luteal phase.
Yes.
So, but yeah, anyway, I actually saw this test, and what attracted me to this was actually more of the pricing. Because when I'm always so tempted to do cycle mapping on patients, especially with irregular periods, and just trying to find out what's going on with them. But if you compare the price, maybe later on you'll discuss that, that a cycle map is very expensive compared to the amount that you will, I guess, spend on the wands here to just get a good idea of how the cycle would look like versus the urine metabolites. Though you would notice that it's not offering us the same results of what, let's say, a common urinary metabolism test would provide. Like 2OH, 4OH, 16OH is not here, but still, this is something of a guide that clinically still has bearing.
Yes. And again, it can help you to then decide, I want to do more of those tests, or I need to do more of those tests, or you can wait. So I think not only does it replace the cycle mapping, but then it helps you to be, the expensive tests that you do want to do, you can make it be more effective and accurate and useful for you.
Do you have a testosterone wand here too?
Unfortunately not, but we are asking for feedback if that's something that you would want. We want to know how often would you want testosterone checked? Urinary metabolites, the benefit to them is you can do them very often. But would you want testosterone more than once a cycle, multiple times, just, here and there? What would be your request for that?
I don't know. Does testosterone cycle? I don't think it does.
So that is, with a patient like PCOS, would you want it more often because you suspect a problem with their testosterone?
Can you go back to the
perimenopausal patient?
Can you go back to the PCOS slide?
Yeah. Which one? I actually showed lots, but do you mean the one?
Well, show me where nobody's touched it yet and they just show up and
This is the one where they had the non-ovulatory LH surge. But this is her pre-cycle. But I would tell you that we actually have found multiple variations of PCOS. So we all knew that, there's multiple presentations of PCOS, but even the hormonal data themselves, we've seen some patients with PCOS have really high estrogen, some have really suppressed, and then, it takes them 30 days and then they finally have an estrogen rise. And then some, we see this pattern here where it's this reversed. And so, even that is something super fascinating that, again, we've never had this much detail on someone's hormones with PCOS to even be able to identify that.
Okay. So
Go ahead.
you go ahead, Doctor.
Oh, yeah, I'm curious because you're saying that the patient can actually buy this themselves, but from the
Yes.
sound of it, they need interpretation from a provider. So why not just make it exclusively be distributed by a provider, and let's not subject these patients to misinterpretations if they're going to try to interpret it on their own.
Sure. So, well, should we stop the recording so I can talk about some specifics?
Oh,
Yeah. Okay. Yeah, we can do that. Okay, hang on. All right. Well, thank you so much. And it's been great.